Up to this point in this course, we've talked extensively about individual joints, isolated muscle function, and normal gait mechanics. This lecture is where everything finally comes together. Today is about clinical application, meaning how we take gait theory, biomechanics, strength, range of motion, and motor control, and use them to make real clinical decisions. This is also the lecture where I expect you to stop thinking like students and start thinking like clinicians. By the end of this session, you should be able to do the following. First, describe normal gait mechanics across all phases. Not just list the phases, but understand what each joint and muscle is responsible during those phases. Second, explain how ground reaction forces and center of mass displacement influence gait efficiency. This is critical for understanding why patients fatigue, why pain develops, and why compensations occur. Third, identify normal and abnormal muscle activation patterns during gait. Strength alone is not enough. Timing matters. Fourth, recognize common gait deviations and accurately link them to specific impairments, not guesses. Fifth, apply corrective exercises based on your findings, not just generic strengthening. Sixth, interpret EMG findings and relate them back to functional gait. And finally, integrate gait analysis into clinical decision-making, not just academic discussion. Biomechanics. This slide represents the foundation of everything we do as physical therapists. Biomechanics explains why movement looks the way it does. When gait looks abnormal, it is not random. It is a biomechanical solution to the problem. Your job is to not judge the movement. Your job is to understand what problem the body is solving. Normal gait mechanics. Let's walk through the phases of gait again, but this time with clinical purpose. We have initial contact, loading response, mid stance, terminal stance, pre-swing, initial swing, mid-swing, and terminal swing. Each phase has specific joint actions, muscle demands, and mechanical goals. At initial contact, the goal is positioning and stability. At loading response, the goal is shock absorption. At mid stance, the goal is single limb stability. At terminal stance, the goal is forward propulsion. At swing, the goal is limb clearance and preparation for the next step. If a deviation appears in a phase, it tells you which goal is not being met. Key motions. Let's break down these key motions clinically. Heel strike, followed by controlled plantar flexion, tells you the dorsiflexors are eccentrically controlling foot lowering. During mid stance, the tibial advancement must occur, which requires adequate ankle dorsiflexion and plantar flexion control, while the pelvis remains level, requiring hip abductors. During terminal stance, push-off must occur via the gastroc-soleus complex. This is where forward momentum is generated. During swing, the limb must clear the ground and decelerate appropriately in terminal swing. If any one of these motions fail, the body compensates elsewhere. Ground reaction forces represent external forces acting on the body during gait. Vertical ground reaction force has a double peak pattern. The first peak occurs during loading response. The second peak occurs during push-off. Anterior-posterior ground reaction force shows a braking force early in stance and a propulsion force late in stance. The medial-lateral ground reaction force reflects balance control. Clinically, excessive ground reaction force often indicates stiff gait, poor shock absorption, or fear. Low ground reaction force often indicates weak push-off, pain, or reduced confidence. In normal gait, the center of mass moves efficiently. Vertically, about 5 centimeters in a smooth sinusoidal curve. Medial-laterally, about 2 centimeters. When vertical center of mass displacement increases, energy cost increases. This is commonly seen with stiff knee gait, vaulting, and toe walking. When the lateral center of mass displacement increases, balance demands increase. This is commonly seen with weak hip abductors, neurologic impairments, or having a fear of falling. Patients don't complain about center of mass. They complain about fatigue, instability, or pain, which are consequences of inefficient center of mass movement. Now let's talk about muscle timing. During initial contact to loading response, Tibialis anterior works eccentrically. The quadriceps control knee flexion. Gluteus medius and maximus stabilize the pelvis. During mid-stance to terminal stance, plantar flexors work eccentrically, then concentrically. Hip and knee stabilizers maintain alignment. During pre-swing to swing, ellipsoas initiates hip flexion. Tibialis anterior clears the foot. And the hamstrings eccentrically decelerate the limb in terminal swing. Clinically, you can have normal strength but abnormal timing, and gait will still be abnormal.